So, yeah, so the recording is going on. So, hello everyone. The RSPH Data Analysis in Population Health Hub is really pleased to present this panel session. My name is Grace Joshi. I'm a fellow and biostatistician at NEJM. Before we start, I wish to acknowledge the traditional custodians of the lands on which we meet today and pay my respect to the elders past and present. Also some Zoom etiquettes before we start. Please keep your audio on mute unless you're speaking. Some people may have bandwidth issues, so it might be better for people other than speakers to turn off their video. We have a really exciting list of panelists today. So the panelists will be presenting their views, and then we will open the floor for questions from the audience. So we have today Dr. John McDonald. He's no stranger to the statistics community in Canberra. Welcome, John. The visiting fellow at the ANU Mathematics Institute and an associate with Statistics Research Associates based in Wellington, New Zealand. So John is joining us from New Zealand today. We have Associate Professor Bruce Shergold from the Biological Data Sciences Institute and the Med School at ANU. And from within RSPH, we have Associate Professor Colleen, who's a clinician and infectious diseases epidemiologist, as well as Professor Emily Banks, public health physician and epidemiologist. I'm incredibly thankful to all the panelists for making time today. We are all really caught up with heavy loads, COVID and non-COVID related research at the moment. So in this midst of this busy schedule, I'm really thankful. So I'll start with a brief intro to what we are getting today. So in March 2020, President Trump announced that the FDA would fast-track approval of COVID treatments, including hydroxychloroquine. And over the next couple of months, many of Trump's public health advisors, including doctors Rick Bright and Anthony Fauci, pushed back on his statements that the drug is safe and effective. So it's in the midst of this really politically charged debate that in May 2020, the prestigious journal Lancet published a global study on the use of hydroxychloroquine for treatment of COVID-19. So it included analysis of 96,000 hospitalized COVID patients spanning from across 6 continents, and the study showed that the people treated with the drug were more likely to develop irregular heartbeats, which can lead to sudden cardiac deaths. Well, many were not convinced of the results. And I know that at least, this prompted very active discussions within the statistical community. And this included John, who is one of our panelists today. So within a week, more than 120 researchers and medical professionals from around the world wrote an open letter to the editor of the Lancet, raising serious concerns about the methodology and data integrity of this article. And it was soon retracted. So this incident and other similar retractions from prestigious journals like the NEJM, they have raised serious questions about, what are the implications of this for research practices? What does this mean for research using big data? Is there a problem with the current peer review process? What can we do to improve the situation? What checks can we put in place to ensure data integrity and transparency? So I'm hoping that the panelists will address some of these issues through brief presentations, and then we will open the floor for questions. So over to you, John.
Okay, well, I'll share my screen. Hope I can get this to work all right. share. Okay, oh now, yep. I've got to find the screen now. Sorry. Here you go. Right. I've taken an interest for a while in issues of what's been called the, what was originally called the replication, the debate on reproducibility, and it's now come to be called the debate on replication. The idea behind the change of language is that reproducibility is now being commonly used to refer to reproducing the actual analysis given the code and the data, whereas replication is repeating the whole study or doing work that sheds light on the original study and perhaps even challenges it. Right, so Sapin Desai, who was who's CEO of Surgisphere, or was, because Surgisphere seems now to have disappeared from the planet, was one of 4 authors on 2 papers. One was the Lancet paper that was mentioned, looking at the effect of hydroxychloroquine, data from 7 hospitals at 6 continents. Another that appeared in June was a paper from the New England Journal of Medicine on blood pressure drugs, 169 hospitals from 3 continents. It turned out that other authors than Desai had no involvement with the data, and finally were forced to write a letter asking for the papers to be retracted.
John, sorry to interrupt you for a moment. We can't really see the screen. There's only a bar appearing. Do you mean to share a screen?
It says you are screen sharing on mine, so what on earth is going on?
Are you intending to share the HTML document, or is it another presentation?
I'm attempting to share the document, yes.
So, John, when you're doing screen sharing, it gives you options for which screen you're sharing or which image you're sharing. So you can, if you go to stop sharing, and then you go to share, you should be able to select. So you need to get on your computer, you need to get up the file you want to share, open.
And then do screen sharing.
Then do screen sharing, yeah.
Okay. Right, and the problem is I can't now see the.
So if it's the HTML document you put together, I can share that screen.
No, this is these are basically slides.
If you minimize it slightly, if you just make it a smaller window, you should be able to see the Zoom window underneath it.
Oh, right, yes, okay.
Otherwise, you could email it to Grace and she can upload it.
The trouble is, okay, if I click share screen with the document showing, will it show it?
Should do, yep.
Oh, okay. I thought I had done that. Here we go. Now can you see that?
It's appearing partly. Oh yeah, now it's good.
Okay, right, good. Sorry about that.
No worries.
So it turned out that other authors than Desai had no involvement with the data. And it's an interesting question, where and how did Desai get his data? Or was there perhaps no data, and he invented a set of results? This seems to have been an amazingly audacious heist. just generally commenting on the issue of big data, yes, we do want all the relevant data. Studies of medical practice variations have gone back a long time. And in fact, Florence Nightingale was published a piece of her research into I think they called them lying-in institutions. It was deaths in lying-in institutions right across Europe, and you know, commenting that obviously something was wrong in some places. For untried drugs with a new disease, observational data has, I think, very limited usefulness. One needs to actually to understand the animal that one's dealing with in order to adjust the observational data properties for differences between the treatment and control groups. In public health, confidentiality issues are difficult, but maybe easier for randomized controlled trials than they are for observational studies. Just as a passing thought, asking other people, does anyone know of a precedent for collecting individual health data on the scale that Surgisphere claimed? I mean, to get that, a data set of that size together, as a number of people have pointed out, in a very short period of time would have been a massive piece of work, and it was not plausible the small number of people that Surgisphere had working for them could have done it. If anyone wants to pop in with comments, that's fine by me. So is the peer review process broken? One hopes that other journals do a better job than Lancet. They don't have a good record. They let the Andrew Wakefield MMR vaccine paper through. That paper was based just on 12 individuals. 12 children had been vaccinated, and he misrepresented the medical information, and so he was struck off the medical register for fraud. So there was both fraud and evidence that even if it was properly collected, was totally inadequate. Andrew Gelman's assessment on peer review is the problem with peer review is the peers. Who are the peers of 4 MDs writing up an observational study? 4 more MDs who know just as little about the topic? But I see the appeal of peer review as a preferable alternative to a pure old boys network. One problem with the attention given to the fatally flawed papers that get retracted is that we forget all the fatally flawed papers that aren't retracted. And then he goes on to say, instead of thinking of the alternative to peer review as backroom politics, think of the alternative to peer review as post-publication review. And of course, that's exactly what's happened in these cases. But I think it's only part of the answer. Clearly, there has to be some modest screening in advance of publication or putting the paper as a paper that's worthy of attention on the web. And Lancet was clearly not up to the task. Incidentally, it's the same editor, Richard Horton, that was involved with the Wakefield paper. I'm going to suggest that we know pretty well how to do randomized controlled trials. It's a bit more complicated than doing coin tossing and checking what you see, a bit more complicated than having people lined up in a queue, and you toss a coin to decide, A is going to go to control, B is going to go to treatment, and so you go on. But not a lot more complicated. Of course, actually managing the whole thing is a huge exercise, particularly where you're dealing with large amounts of data. But there are some excellent randomized control studies underway with COVID-19 treatments, and several of these have already given useful results. Whereas, what do we get from observational studies? The kind of confusion that even with good data, what one sees from the analyses that were presented in the Lancet and NEJM papers. What is known and understood is widely ignored. I've given a number of references, as Gelman also does, in the notes, to which is a link on the comments page, to studies that I would judge are totally inadequate. An important point is that artificial intelligence and data analytics may offer new ways to manipulate the data, but they face the same traps. And they can, in the marvellous words of O'Neill's book, be weapons of mass destruction. These issues feed into the wider debate on replication and reproducibility in science. Multiple well-designed studies provide the clinching evidence. Replication studies can be useful in identifying the limits of what we think we know. We are learning new ways to look at and use studies, and I think we're getting to the point where the old ways of doing things that we've inherited from the 16th century are no longer adequate for the job that we have today. And we've not really learned to take proper advantage of the resources that the new net-based technologies offer. This is just a very brief summary of much more detailed comments that I've put on the link that I've posted under comments. Thank you.
Thank you, John. That's very interesting points raised there. I would like to invite Emily to present her views on that.
Thanks so much, Grace. John, do you think you can stop sharing your screen, please?
Oh, yes, sorry, yes.
Okay. Okay, thank you very much, John, and to Grace and the organisers for giving me this opportunity to speak. I'd like to also acknowledge the traditional custodians of the land that we're meeting on, the Ngunnawal Ngambri people, and pay my respects to elders past and present. I totally agree with the comments that John has made. I think the key question here is what I would call horses for courses. It's about the right evidence for the right problem. So I'd like to start with a quote by Bertolt Brecht that I use a lot in these sorts of things, but what I think we need to bear in mind is that the aim of science is not to open the door to infinite wisdom, but to set a limit to infinite error. And so we're room full of ideas what might help with COVID, what might not help, but we need data and science. So it actually has a thing that it's in fact data that sits in that too, to tell us when we've gone wrong, so we can be constantly experimenting. Now, we need to, in this case, think about the right evidence for the right problem. Now, I think when we think about the issue with the Surgisphere paper, probably a glaring issue, and the one that has mainly been brought to bear, is the quality issue, that there are a whole lot of questions about the quality of the data here. So if we're going to talk about the right evidence, the right problem, it's got to be high quality data, but the data have also got to be suitable for and fit for purpose. So I'm not going to talk about the quality issue. I think it seems quite likely, I don't know for sure, but it seems quite likely that there are issues related to fabrication of data, to fraud, to various other things. I don't end up being sued, but it is looking pretty like there are serious problems with the actual quality of the data. I'm going to talk more about whether these data were actually suitable for the question that they were seeking to answer. So if you think about the question that we're seeking to answer, first of all, it was in a sense a question about whether a specific intervention worked. That is, how hydroxychloroquine related to mortality. Now, somehow that seems to be phrased as almost an adverse event, but if you're thinking about hydroxychloroquine in the treatment of COVID-19, you are really talking about wanting something that will actually improve mortality outcomes. There were other outcomes in there, including sort of fatal or life-threatening arrhythmias and other adverse events. But essentially, the main thing that we start by looking at is saying, well, what is the evidence that this treatment, hydroxychloroquine, works? Now, so that is very important when you're considering which are the best data. You do need to think about the clarity on what the endpoints are and whether it's a treatment effect or whether it's a kind of safety thing. Now, if you're looking at whether a treatment actually works, by and large, almost exclusively, you need randomized data. There are occasions when it is such a huge effect of something that you might be able to see it reliably with observational data, but by and large, what we are talking about is moderate effects, and by and large, you have to have randomized control trial data. Now, I know people say, oh, but it must be possible to show it. It must be possible. And that's where a lot of this comparative effectiveness research comes out. It must be possible to adjust for everything and come out with an effect. But unfortunately, by and large, it is not. So observational data do not generally yield, well, pretty much never, almost never yield evidence we can absolutely rely on about whether interventions work. People raise quite a lot of issues about the generalizability of randomized control trials. I think that stuff is overstated. It's not something I can go into in detail here, but I'm happy to talk about it separately and happy to circulate a paper on that. So if you're looking at the safety of interventions, so that's where we're talking about the relationship of hydroxychloroquine to, for example, arrhythmias. You still need randomized data for many outcomes. Observational data are generally unlikely to be suitable for outcomes that are preceded by sort of long disease processes or a whole lot of other features that will affect exposure. I'll go into this a bit more detail, but if you're talking about mortality, mortality doesn't usually happen sort of out of the blue. People usually have quite a few diseases and other things that then that end in a mortality outcome. You see the same with cardiovascular disease. It's quite a long program, and we particularly see it with dementia. It is possible to extremely judiciously use observational data for selected safety outcomes, but this requires detailed content understanding. It really means expertise and understanding that disease, understanding or that outcome, all the different risk factors, and you need to be able to actually capture that risk very well. So you can use observational data for some outcomes, and particularly those that are unpredictable, that have a random event, sort of element, without chronic or subclinical disease issues. So they're kind of certain cancers or venous thromboembolism. So whereas we think of, I think if we're talking about horses, I'll keep going with that analogy, randomized control trials are kind of like the dressage, very highly formalized, sort of very formulaic, and observational data are kind of the Brumbies, the wild horses of the data world, and you need to be very careful about how you use them. I would also add another analogy here that when you're using observational data for selected safety outcomes, what matters is the sum total of the evidence, not just your specific study, but all the other studies and all of the other things that are known. And I often think in terms of the orchestra being in tune. So why is it that you can't really use observational data to look at treatment effects or many actual side effects? The main thing is uncontrolled confounding, and the other thing is reverse causality. Now, people often think, oh, and then there's human nature, that people generally, when they see positive results, they will tend to believe them. The other thing is our industry. We tend to publish a lot on different observational studies. So, but you actually do need to be able to capture uncontrolled confounding and capture confounding and reverse causality. And people often say, oh, well, we can do all these technical fixes like adjustment, propensity matching, artificial intelligence, machine learning, they cannot actually fix things that cannot be properly measured. They can only adjust for things that can be measured. And the problem with a lot of looking at interventions is there are things that dictate whether or not people are exposed to things which are not able to be captured properly. So, so if I look at this sort of, if you want to do a schema about it, if you imagine you've got a background pathological process that's going on in the background, and so in this case you could do an example, but it's atherosclerosis, but it might also be the progress of COVID-19. You've got a background pathological process. Then you've got things that are visible. At the beginning, people are well, then they might have subclinical symptoms, then they might go on to be symptomatic, and then they might have a disease event. And you have impairment, psychological effect. And then what you have is that those things influence your exposures. So if you can imagine in this situation with COVID, you've got progression of their disease happening that will then influence whether or not they are offered hydroxychloroquine. You can capture some of that in some of the data that you see clinically. And if you look at Surgisphere, they tried to, wherever those data came from, they tried to look at things like people's oxygen saturation, but they would not be able to capture all of the dynamic processes that were involved in the judgment of whether or not people were given that hydroxychloroquine. And it would be perfectly reasonable for that hydroxychloroquine to be given to people who had more severe disease. So what you have is the exposure being influenced by the disease process. And then what you have is what is visible in clinical data and in your large scale data. So often the underlying clinical processes that go to influence exposure are not able to be detected in the data that we have. So so for example, with atherosclerosis, people actually feel pretty terrible and have impaired circulation for quite a while before they have a myocardial infarction. And that feeling terrible and looking a funny color, for example, might influence whether or not a GP offers medication. It might influence whether or not someone exercises. It might influence their sleep. But we don't see, we can't tell about that feeling lousy part. All we see is, for example, that, and then those people who have that underlying pathological process are more likely to go on and have a myocardial infarction. It's a myocardial infarction that shows up in the data that we have. So from our point of view, it might look like people who sleep more have an increased risk of myocardial infarction, but it's actually because people who have that disease process going on sleep more, and they're also more likely to have myocardial infarction. So this is just one way of sort of presenting the schema. You can apply it across a lot of things, but it's behind a huge number of what I would call memes in epidemiology, which is where the underlying disease process or all the things that precede an event influence exposure, and then they create this misleading series of results. So I would ask myself, how many times do we have to repeat this particular mistake? What happens is observational studies show exposed people have a different outcome compared to unexposed people. So we've got multiple, there's thousands of examples of this. One of the most classic is in vitamins and cancer. People who take vitamins tend to have a lower risk of cancer, and people have then interpreted it as vitamins reduce your risk of cancer. We saw it with hormone replacement therapy and cardiovascular disease, hormone replacement therapy and dementia, hormone replacement therapy and mortality, this so-called antioxidants in cancer, sleep and cardiovascular disease, sleep and mortality, and we've got hydroxychloroquine and mortality. Now, people get very excited after they see the observational data, they form beliefs, and then they do things. And then later, if a randomized trial is conducted, they often show something different. So the observational studies showed that people who took vitamins had reduced risk of cancer. One of the most famous, and that was particularly around beta carotene, and a couple of randomized trials actually had to be halted because there was higher death rates in people randomized to beta carotene than those who hadn't. We're in the middle of doing exactly this for vitamin D. Anyway, the beliefs often persist. So we still have Uncle Toby's plus antioxidants, even though there's actually really no evidence that these antioxidants prevent illness. So I would conclude that we have to be very careful about where our beliefs come from, and this is a quote from Voltaire, which says, "Those that make you believe absurdities can make you commit atrocities." So we've been fortunate that the scientific community has really come on board very quickly about this particular article, but we need to think about all the other articles that are out there that are invisible, that are influencing our beliefs and what we do. Thanks.
Thank you, Emily. So people might have questions. So what we're thinking of is have questions reserved, like a discussion open at the end of all the presentations. So Bruce is going to go next with his presentation.
Okay. How is that? Looking good. Thank you,
That's good.
Grace, for inviting me on this panel, and I'm very honored to be amongst these distinguished panelists that I'm here with today. My presentation is trying to, I suppose, dovetail on the back of what John and Emily have done. Emily gave us a great rundown of evidence-based medicine and how we should apply it. And John gave us sort of the I suppose, an introduction and a walkthrough of how those things came about with the retraction of those papers. I'm going to give you a little bit of a background about what I suppose my personal experience has been over the last 27 years. And I give a similar presentation to this back in 2016, where I was saying we need to put science back into research. Just in terms of that, I'm a epidemiologist statistician, and I've been on numerous teams or as a consultant over 27 years on clinical research undertaken in the ACT. And just to sort of follow up with sort of the examples that have been talked about through the retraction of the papers that we've seen, the type of researchers that have come through my door, their yeah, somebody's not mute. Thank you. So I get potential researchers, PhDs in particular, come through the door and they have no idea about study design. That's a big problem, as we saw with Emily's presentation. Knowing the horses for courses. Actually, I'm wearing my hot riding jacket, Emily, so it was well timed with it. You know, you've got to be able to understand what it is that you're trying to do from a methodological point of view. So that's one type of problem that I'm seeing. The next one is I'm seeing researchers come through extremely desperate to find a significant result with the data that they've brought to me. And they'll try any data manipulation to get that data significant. And it may be that's what's, you know, it sort of flows on in terms of that idea that potentially there's been some sort of a process in place. I don't want to say, as Emily said, we're very reluctant to say what the issues were there in terms of data quality, but there is that type of, and the main reason is they're trying to present this data at a conference or a publication, or they've just been collecting this data for a number of years. It's not easy to do, and they want to be able to demonstrate that they've found something that supports their initial idea, their hypothesis that they've come up with. Typically, they don't have a hypothesis. They don't even know they're testing a hypothesis. And you know, they feel like they've failed if they haven't shown that there is a significant association with the variables that they're looking at. The next one is, and again, this is a bit like Emily was saying, this data fit for purpose. So typically they'll have a data set. It won't have confounders that are necessarily measured. This is in some sort of observational type of study design. They haven't got all the confounders there. They haven't got the important confounders in their data set, or they might even have measured the baseline. And yet they want to be able to analyze this data and present this data for publication or for at a conference or something like that with their peers. This is a major problem because quite often it means that if there's a data set out there, people will try and grab that data set and see what they can do with it. And then they'll just
You're muted, Bruce. You've suddenly gone muted.
How is that?
Yeah, we can hear you now.
Sorry, and did you get that one that I just mentioned or not?
Perhaps the last sentence. Just would you be able to repeat that?
The last sentence was that unfortunately, researchers will latch on to data if they get hold of it, because there's quite a lot of data available, and they think that it's fine to have these limitations in their data and just to describe them, and that should be good enough for publication for research. They're not seeing that they need to actually have a well-constructed scientific study that is what you should then working towards in terms of sharing that with the world in terms through publication. And the other one is that quite often I get people who add data together with different study designs. You would think this would not happen, but it does. They might have a cohort study. They've figured out they haven't got a large enough sample size, so then they'll add cross-sectional data or whatever it is that they can find to be able to bolster the numbers of patients or numbers of participants in that study. And that's not an uncommon problem that comes through my door. And I suppose this is by far the biggest issue is this inadequate sample size. And that's fine if you're in a situation where you have got an inadequate sample size, but there's no plan of saying how we can move forward with this, that this could be a pilot for a bigger study, or there's none of this type of mentality. It's what have I got available to me? How can I take that for publication? How can I take that for a conference? How can I get a qualification from this? So it's not really doing research for the sake of adding to our scientific knowledge. It's doing research for the sake of being able to gain some other benefit from it. I'll just close this, sorry. Just as a bit of more background, I've also been a clinical trials consultant for Merck Sharp and Dohme. Basically did a lot of their work around metformin and type 1 diabetes, type 2 diabetes. I did work with Pharmaxis, their work with mannitol and now called Bronchitol for bronchial challenge tests and for cystic fibrosis treatments. And I did a lot of the clinical trials work for the Commonwealth in relation to aged care assessments. So I ran those clinical trials for them across Australia. And I'll talk a little bit about those different clinical trial designs that are now becoming quite common overseas and just starting to appear in Australia in terms of those response adaptive designs. John, you may want to know a little bit about those. They're coming up. We're about 10 years behind here in Australia in terms of those types. And I'm seeing also in terms of recent COVIDs that have highlighted these systematic issues, I think, for research. So I'm hoping that, and we can see them coming up in terms of the types of surveys that are coming out and the sampling methodology they're using. It's almost like market research is coming out of our university, and it's worrying me. So what's happening? So recognize this about quality. Emily's covered this to some extent. John's covered the explosion of data. It's driven by technology-based knowledge economy. Obviously, we're able to get data now across sectors from education services, from our cars where we go and get them registered. It all is coming together and as a large, big data approach to being able to access and look at how we can utilize that data for research. So 20 years ago, the fear was that it's easy to access statistical software. Now that fear has been multiplied by now being able to access volumes of large data. I don't know whether you can remember, but there was a lot of problems when software like SPSS and others came out, and pretty much anybody could run a query or a syntax over that data and it would come up with a result. and that was then getting published into the literature by a variety of different people with different backgrounds. Basically, as long as you can push a button, you're on your way.
Bruce, just a heads up that we are coming close to the 10 minutes limit.
I will, this is sort of the data quality that we're seeing at the, in ACT. I won't go through it too much, but basically the average number of research projects that are of a high quality per researcher is pretty low. It's about 0.4, lowering over time, as we can see there with the trends. So my question is, who's responsible? We've talked about journals and reviewers, but I think researchers are also responsible. Generalizability, reproducibility, replication is critical to all of this. I think we need to work hard at those things. There's some generalized frameworks for the evaluation of clinical trials. I can give you some references there, but I'm happy to provide further references on that. There's the evidence-based medicine assessment tools. There's the Centre for Evidence-Based Medicine over in Oxford. They have a great set of tools online that you can access and look at how you can assess things. With the general framework, you've got, you know, the Consort, you've got Cochrane, you've got a few others that you can go to get some sort of assessment tool. And in terms of reproducibility science, the Data Science Institute that I'm with, they're actually running a course on it. So I suggest if you're very interested in that, go along and see what's happening there. Dimensions of clinical trial quality. There's the dimensions. A lot of it is around bias. A lot of it is around procedures. They're well established and should be followed, I think, as much as possible. I'm happy to share these slides. This is the response adaptive clinical trials methodologies. This is an example. I won't go through it in too much detail other than to say a lot of this is now being called platform technology. And you can, it's a way to be able to, I suppose, have a more efficient way to run trials. They go across phases. They use less patients. They use less events. Take shorter time to do. That's their positive. There's negatives to that as well.
Thank you, Bruce. I think we may have to kind of, you know, take further questions, and we're getting questions from the audience. So perhaps what we can do is quickly check with Colleen. Would you like to add anything before we start taking questions?
Thanks, Grace. I don't have a formal presentation, but just want to make a few points related to what the other speakers mentioned. So Emily's point about the beliefs persisting even after they've been disproven is a really big issue. So getting back to this hydroxychloroquine paper that's just been retracted, just want to share some personal experiences related to that. So I'm on a data safety review board for a clinical trial at the moment on the use of hydroxychloroquine as prophylaxis for healthcare workers. And so when this paper came out, it was, of course, you know, we looked at it very closely and decided that even if the data were real, that we didn't really believe in the results. So we didn't do anything in terms of stopping our study or anything like that. But as a result, it's, I think, created a lot of problems with poor publicity related to science in general, but also related to, you know, to the drug. And it will probably become quite difficult to recruit participants for the study. So the study was about, you know, I mean, the retracted paper was about using the drug for treatment, whereas we're using it for prophylaxis. But not everybody really understands the difference between these things in the general public. So the reduced public confidence was a really a big issue, and these beliefs will persist, unfortunately. And there are still YouTube videos online from Sapan Desai discussing the findings of the now retracted study. And not everybody would realize that it's retracted.
Thank you, Colleen. So we have a couple of questions. in the chat box, and I think I'm just getting through to them. Emily has actually answered some of them. So one of the, I'm just going through the first one was about one of the giants in observational studies is Donald Rubin, who created the Rubin causality model, and how relevant is this for his model for epidemiological studies. So Emily, yeah,
I think it's worth talking about this, because I think it just, to take a step back from it, there's an idea almost that you can get around some of these issues about reverse causality and confounding by doing these quite complex causal modeling. So things like directed acyclic graphs and all these other sorts of things, and then using statistical methods that go with that. Now, it definitely has a place to think through what you think the likely confounding factors and what reverse causality might be operating. It's definitely good to draw yourself a causal diagram and to really think a priori about what you're going to need to account for. But ultimately, these are tools, and you still need to be able to make a judgment about whether uncontrolled confounding is likely to be affecting your outcomes. And I still think it doesn't solve the problem that you can't really use observational data to look at interventions and their efficacy. So I think those things are useful tools. I personally have not heard of this person or have used their model, so I can't really comment on that. There was another question which I thought I might just tag my answer onto the end of as well, which is a question about whether clinicians are particularly doing this kind of research that's unsound, or whether they're people who are doing this kind of not respecting what it takes to make a study great. And I think it is very true that people think of epidemiology, public health, and to some extent statistical research as being kind of intuitive. So I'll often give a talk at grand rounds or something like that, and there'll be at least one clinician who will come up to me at the end and go, "Oh, that was really interesting. Do you think I could come around and have a kind of play in your data set?" And I say, "Oh, look, as long as you don't mind me coming having a play in your cardiac catheterization lab, you know, or maybe just trying my hand at a heart transplant." There's a kind of an idea that you don't need really extensive training and expertise to understand it. And one of the most productive collaborations I've been involved with was through the Cardiovascular Research Network, which actually brought together cardiologists and clinicians with people doing public health and epidemiological research. And it really brought, I think, a whole new level of respect for what we do, because you could see how lost people are at the beginning, especially with very large scale data, and how important it is to then show them how you would work through the steps. And even, I think Bruce's point's really important, even things like getting people to write an analysis plan before they start analysing the data. Even that, clinicians, well, no offence to clinicians here, I did train in clinical medicine myself, so I think I can sort of say a bit about it. People will balk at that and say, "Well, I just want to get in there. You know, I think I know what I'm doing." But actually, that's just, it's just plain wrong if you don't actually state your hypothesis first, if you don't state what you're going to do and how you're going to address it. You will find irreproducible results.
technically that's really interesting. Colleen, you would like to make a comment on that?
I'll just following up on Emily's comment. I fully agree with that, and you know, we really need a subject expert in these sorts of studies as well. So, you know, as Emily said, you know, you do need this very strong analytical expertise, but then there are people who grab big data sets and go and analyze them without any appropriate context in that field. So just to give another example, my background is in clinical medicine as well as in family medicine and as a travel medicine doctor. So I was sent a research paper which looked beautiful, and lots of work had clearly been put into it, that looked at the changing trends in the incidence of malaria, dengue and chikungunya in Europe. And I thought, wow, this is going to be interesting. And it used 8 years worth of data from the European CDC. So there are, you know, amazing data sets that are just publicly made available. So I'll just share my screen with you, and you can see like this sort of you know, atlases and like many hundreds of data sets that are just publicly available. So what they did was they did these beautiful analyses and maps and showed that there were these large numbers of locally transmitted malaria cases, dengue and chikungunya all over Europe. And I just took one look at it. I said, this can't be right. You know, this is just absolutely not going to be true without even reading the paper. And so what it turned out was wrong was that in these data sets, there is a variable for international travel. And it was yes or no, but the majority were missing. And the ones that were missing, they just assumed that was no, that they hadn't traveled. And so all those were coded as locally acquired cases. And so, you know, just something really simple like that to give, you know, context to the results and whether the results are even plausible. So that's one example. And then in the end, they decided it was just way too difficult to do anything with that data set because that information was just missing for the majority of data points. And then a more recent example on a study that was published on COVID-19, looking at the effectiveness of the travel bans in Australia that were put in place against travellers from China, using, you know, publicly available data sets from China, etc., a number of cases in Australia, and showing that the travel bans were highly effective and reduced imported cases and deaths by something like 87%. I thought, wow, that's impressive because, you know, there's very little information about the effectiveness of travel bans. But if you read the paper, which is now published, unfortunately, in the Journal of Travel Medicine, I'm planning to write to the editor about it. I'm on the editorial board for that. Not once did they mention that the epicenter had actually been isolated. Like they've shut down the whole city of Wuhan, the whole province of Hubei before Australia implemented travel bans. So that they did not even take that into account in their analyses at all, used basically travel data that were from 2019. And more than 90% of cases came from that epicenter. So basically all the analyses just, you know, they just don't make any sense. But it's now published saying how effective it is and that this information should be used to inform future recommendations regarding travel bans. So I think, you know, and that's just a couple of sort of personal examples of where you really need a subject expert as well, and not just the data and analysis side of a team.
Thank you, Colleen. That's quite right. I'm just quoting Desai here. If you're using big data, artificial intelligence, and machine learning to measure the world, do you really need an RCT? So that's the kind of thinking that's coming from some people here. And the answer is yes. Yes, absolutely. There are a couple more. Oh, I'm conscious of time. We have about 4 minutes left before we wind up the session. There is one question about would investing more in the teaching of statistics or study designs to medical students would be a way to help instigate the cultural change required among clinicians to allow them to appreciate the expertise required. So, I don't know, would that be a question for Bruce?
I think definitely, but that would have to be combined with them understanding that working in teams to do research is the way to go. As Emily and Colleen have suggested, it's really about bringing that expertise together that you get the real research quality coming out. So it's that content expert, it's that clinical experience expert, it's the epidemiologist, it's the biostatistician, and whoever else is needed to come into that team and then work through those projects together from the very start to the very end. And it's not just a consultancy type of approach, it's a team approach. I think that is the key. But here, exposing medical students and other students to those things is extremely important, but having that as also part of the teaching.
Thank you, Bruce. Yeah.
Can I add too that I think it has to be taught in a very particular way to people. Like, I think they need to understand the meaning and utility of it. So I think they need to understand. I mean, I found that as a medical student, the main thing that people wanted was you had to put the frightness on them that they might make a mistake in the emergency department. Because most people just think, I don't want to kill anybody when I get out there, you know. So if you can explain that actually, if you don't understand statistics properly, you will make mistakes that will kill people. But you have to, obviously, you have to do it you frame it in the right way, but people have to understand not only about statistics, but how important it is, and also how you do need to be working with a statistician rather than thinking you can just do it all yourself, as Desai seems to have done.
That's good.
Yeah, I agree with Emily. I think it's probably not realistic to train all medical students to be competent in statistics, and that, you know, there's so much to do in medical school already. Just like it's not possible to train epidemiologists to be competent clinicians. But I think the important message there is that they need to know their limitations, so they need to know what they don't know, so that, you know, so that they get the right expertise when necessary.
I think the problem actually goes beyond that, that you have people being trained in public health, who are being trained in these rather facile uses of propensity scores or whatever, or just straight regression methods, with the idea that these don't require the kind of checks that Colleen and Emily and Bruce have drawn attention to.
Thank you. I just want to outline, we have about another 1 minute left. So I'd like to just take you through some of the other questions. Erin has raised a point about doing research for research's sake, and its impact on people thinking about data quality could be symptomatic of short-term contracts on the academic side. So it's about, you know, when large studies in great teams take a lot of time to conceptualize and publish, what does that mean for actual short-term contracts? There's a question from Jenny about approach to peer review. Do we need teams approach to peer review as well? That resonates well with me. Well, the like for example, in this study, there are prestigious journals and institutions involved. We have Harvard Med School and Lancet and NEJM. So, like, you know, peer reviewers can take kind of, you know, perceived data quality or at face value without looking at the paper. So would the panelists have anything to comment on any of those?
I think that the problem, like peer review, they say it's like democracy. It's the like least worst system, but it's full of problems. And I do think that high quality peer review is just, you know, it's very hard to find. And the problem with what we're facing now is that people are being judged on the volume of their publications, like the number of publications, rather than on the quality and the impact of their publications. So we're just getting this huge volume. I am not able to do peer review on a lot of papers that I'm sent, and I feel really bad because I think I'm not contributing to that. So I think people do need to be trained in peer review. I think they need to understand the limitations of their expertise. I think we do need better teams. I do agree with Erin's point about the short-termism. I think it makes it very hard to think big, and I think people do think, right, I've got a 2-year contract, I'm supposed to get, you know, X papers per year, and then they're thinking in the terms that Bruce was talking about. How many papers can I get out, and how can I use the data that I've got to make a paper? So I think that all contribute. It's about an overall culture of research. But I think we do make incremental progress as well. So I don't think we should totally throw the baby out with the bathwater. I think we are achieving a lot with research, and we can see that, and it's part of having forums like this. I'm afraid I just want to take the floor too because I have to go, but I wanted to say a really big thank you to everybody. I think this has been a superb presentation and really great attendance and brilliant questions. So thank you.
Thank you, everyone.
There is the issue of post-publication review too, and I think we have the technology to make that, use that much more effectively than we do at the moment.
I would like to thank all the panelists. It's been a really lively and insightful discussion today. So people who, I'm afraid we need to close the questions because we have exceeded the limit, but feel free, keep tuned in to the for future events by the DAP Hub. If you'd like to subscribe to the mailing list for future events, just send in a mail to daphdap.rsph@anu.edu.au. Thank you all.
Thank you.
Thank you. Very good.
Yeah.
Yeah.
Thank you all.